This podcast is sponsored by Zoll LifeVest. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hi everyone, Dan Amender here. On behalf of all of us at Cardio Nerds, we are thrilled to bring you our Decipher the Guideline series for the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. Get ready for short and bite-sized, high-impact clinical vignette-based questions designed to highlight core concepts based on cutting-edge evidence that are relevant to your practice. The cases we use are hypothetical and for educational purposes only. This series was developed by Cardio Nerds and created in collaboration with the American Heart Association and the Heart Failure Society of America. It was created by 30 trainees spanning college students through advanced fellowship with mentorship from Dr. Anu Lala, Dr. Robert Mentz, and Dr. Nancy Schweitzer. We thank Dr. Judy Bezanson and Dr. Elliot Antman for their guidance. So join us as we get to learn about the guidelines and beyond from 16 leading faculty experts. With that said, it's time to get nerdy.
The following question refers to Section 6.1 and 7.4 of the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. The question is asked by Keck School of Medicine USC medical student and Cardio Nerds intern Hirsch Elhen. Answered first by faculty at the University of Chicago and co-chair of the Cardio Nerds Critical Care Cardiology series, Dr. Mark Belkin, and then by expert faculty Dr. Mark Drazner. Dr. Drazner is an advanced heart failure and transplant cardiologist, professor of medicine, and clinical chief of cardiology at UT Southwestern. Dr. Drazner, thank you for being such a supporter and role model for Cardio Nerds. Welcome back to the show.
Thank you. It's my pleasure.
Alec, thanks so much for that intro. So our question today is about a 72-year-old woman with a history of hypertension, type 2 diabetes, and a recent MI who was seen in your clinic. 2 months previously, she was hospitalized with an MI and underwent successful revascularization of the left anterior descending artery with a drug-eluting stent. Following her MI, an echo revealed an EF of 17%. She was discharged on metoprolol succinate, lisinopril, spironolactone, and dapagliflozin, with an escalation to maximum tolerated doses over subsequent visits. A repeat echo performed today in your clinic reveals an EF of 26%. An electrocardiogram reveals normal sinus rhythm with a narrow QRS at a heart rate of 65 beats per minute. She is grateful for her cardiac rehab program and reports no ongoing symptoms. Which of the following devices is indicated for placement at this time? Option A, an implantable loop recorder. Option B, an ICD. Option C, a CRT-D, or option D, a CRT-P. Mark, I would love your help talking about these different devices.
Thanks, Hirsch. That's a great question. The correct answer here is B. This patient suffered a myocardial infarction more than 40 days ago and has been on appropriate guideline-directed medical therapy since that time. Her left ventricular ejection fraction has improved but remains under 30%. For patients who have suffered a myocardial infarction over 40 days prior, with an LVEF less than or equal to 30%, and NYHA class 1 symptoms while receiving GDMT and have a reasonable expectation of meaningful survival for greater than 1 year, an ICD is recommended for primary prevention of sudden cardiac death to reduce total mortality. This is a class 1 indication. This recommendation comes from multiple trials. The MADE IT 2 trial enrolled 1,232 patients with a prior myocardial infarction and LVEF less than or equal to 30% to prophylactic ICD or medical therapy. At a median follow-up of 20 months, the trial was terminated early for reduced all-cause mortality with prophylactic ICD. The DYNAMIT trial later investigated the implantation of ICD in patients with MI and an LVEF less than or equal to 35% at 6 to 40 days after the initial myocardial infarction. This trial found no differences in all-cause mortality between the two groups. Therefore, the current recommendation is to wait at least 40 days with GDMT prior to reevaluation of left ventricular ejection fraction before proceeding with ICD implantation. Choices C and D regarded cardiac resynchronization therapy, or CRT. This entails implanting pacemakers to simultaneously pace both the right and left ventricles in order to improve electrical synchrony. Generally, CRT provides benefit in those with systolic dysfunction and a wide left bundle branch block. Specifically, patients who have an LVEF less than or equal to 35%, sinus rhythm, and a left bundle branch block with a QRS duration greater than or equal to 150 milliseconds, along with NYHA class 2, 3, or ambulatory 4 symptoms while in GDMT. CRT is then indicated to reduce total mortality, reduce hospitalizations, and improve symptoms and quality of life. This is a class 1 indication. CRT implementation provides high economic value in this setting. In patients with reduced LVEF less than or equal to 35% and either a non-left bundle branch block pattern, but a QRS greater than or equal to 150 milliseconds, or a left bundle branch pattern, but a QRS that is 120 to 149 milliseconds, CRT implementation carries a class 2A recommendation. The patient in this question has a narrow QRS and therefore does not have indications for CRT placement at this time. The main takeaway here is that ICD implementation is recommended for primary prophylaxis against ventricular arrhythmias, patients with an LVEF less than or equal to 30%, 40 days following a myocardial infarction despite use of guideline-directed medical therapy. Dr. Drazner, before 40 days post-MI, do you consider other devices such as a light vest? And then how do you approach the timing of ICD in patients with non-ischemic cardiomyopathy?
Yeah, thank you, Mark. Very important question. And we're in some gray areas here, I'll say. First, in terms of using a wearable defibrillator or life vest, the evidence to demonstrate that you could improve outcomes by using this device, although intuitively appealing, has been, I would say, in my opinion, disappointing. The largest trial that I'm aware of was the VEST trial that randomized patients to that strategy and did not show a significant improvement in outcomes. And because of that, as you'll note, there is no guideline recommendation in this document in terms of using a life vest in that 40-day window, let's say post-MI, where I'll say this about life vest. One is it has been shown to be effective at terminating arrhythmias, but we don't have that evidence yet that it can improve outcomes, that's certainly in the primary prevention. An area where I think there's potentially a bigger role would be people who have an ICD who've already had an event, and the ICD has to be explanted for, say, an infection. And let's say you're in a window where you can't reimplant the ICD. The patient's already demonstrated that they're at risk of cardiac arrest because they've already had an event. And there, the potential role of wearing a life vest until you could reimplant the ICD, I think would be a stronger indication than in this situation. The other issue is the timing of the ICD. This is a really interesting question about when do you implant either post-MI or in, let's say, new onset non-ischemic cardiomyopathy. And the issue here is that we have effective GDMT that can, of course, improve ventricular function. Now, in this patient, already we're starting to see recovery with an ejection fraction from 17 to 26%. The guidelines say after 40 days that you can implant the ICD. The question is, if you waited a little longer, would the EF rise such that they would no longer meet the indication? I think this is a gray area. The guidelines would say 40 days, but in my personal practice, if I already start to see recovery, I might hesitate. And then in patients, especially in this question is particularly gray in the patients with non-ischemic cardiomyopathy, where they say in new onset cardiomyopathy, where we say that the ICD is indicated if patients are on GDMT. Well, how long do you give that GDMT and what is GDMT? For example, 3 months is oftentimes thrown around as a number, yet we know that ventricular function can improve all the way up through 12 months. So there's kind of competing risks and benefits. If you have a patient with, let's say, new onset non-ischemic cardiomyopathy, they're on GDMT and now you're at 3 months and the EF is at 32% up from 25%. Do you implant the ICD or do you keep waiting until the EF recovers over 35% and then an ICD is no longer indicated? The risk benefits, as I see that, is in that window while you're waiting, their patient potentially could have an arrhythmic death. On the flip side, if you wait and their ventricular function recovers more and they don't need the defibrillator, you save patients an ICD implant, which comes, of course, with associated risks, including ICD infection. So I think there's a little gray area here in terms of clinical practice. And in my opinion, the guideline, it's a little fuzzy in terms of how long to wait, certainly in a non-ischemic setting. In my personal practice, although it says 40 days, if I saw an EF already was recovering quickly, I'd have a shared decision-making decision with the patient at that point about whether we should try and wait a little bit longer to see if they're going to have full recovery. I guess it also would depend on the magnitude of the myocardial infarction, things like that, in terms of the prediction of whether they're going to recover enough that an ICD ultimately will not be indicated.
Thanks, Dr. Drazner. That was a very nuanced discussion of what I think can be not as clear of an issue as sometimes we talk about GDMT for heart failure with reduced ejection fraction, but when dealing with devices, that it's often not as black and white as the guidelines may seem. But I think overall they do a good job of providing adequate guidance here, but it seems like a lot of learning and experience goes on top of that.
Yeah, and I should say, even now, there are some people who feel for heart failure with non-ischemic cardiomyopathy, whether there's even equipoise to do a randomized trial, for example, because the ICD trials were done with different GDMT than we have available now. So there's a reasonable segment of the community that feels that it is actually ethical to perform a randomized trial of current state GDMT versus ICD. So we'll have to wait to see if that trial gets done, and then the results of that to see if maybe the guidelines might change in the future.
Great. Thank you, Dr. Drazner and Mark. I think for me as an early learner, it's especially helpful to hear about these gray areas because it's something that, I don't think about that much. I'm still trying to learn the basics.
Yeah, and certainly the guidelines are a great place in that setting. They give you a strong, strong foundation. So thank you for pointing that out.